Thank you, Dr. Stuti. So after ESO comes exotropia. Display is not coming. One important point which you said is about four muscle surgery. That is something which I'll come to in due course of time. So coming to the exotropia surgery, how to get perfect straight eyes. Actually, exotropia is one of the commonest strabismus entity which everybody faces, not only the strabismologist but also general ophthalmologists as such, and many of the general ophthalmologists are also handling them. So this is kind of a result which you expect out of exotropia surgery, just a couple of cases, but believe me, in the long run, only 70% will behave this way because they will have a recurrence and things like that. So I'll start with the first case. This was not operated by me actually, it was referred to me after the first surgery. She was a 23-year-old female with history of left eye deviation. Initially it was intermittent, then became constant squint. Something which you need to ask in a case of exotropia is headache or diplopia phobia. Rest of the ophthalmic examination was actually normal in her case. This was the pre-operative photo which the patient shared with me, and she underwent a bilateral recession. I mean, in established institute, so that was the surgery done. The angle appeared to be, to me, actually, I mean, just two muscle perhaps may not have done the proper correction, but to everybody's surprise, this was her post-operative result. Hardly any difference in the pre and post-operative. I thought that she has not been operated only, but on careful examination, there was a scar. I mean, she was operated. So the patient was dissatisfied. So, I mean, I've not seen the surgeon's reaction, but it must be something like this, that what has really gone wrong. Nothing to pat my back because I faced a similar case like that. This is a 20-year-old female who presented to me, almost same age group, similar pattern. Actually, she had a left eye separation, though she appears to be right eye separation, though apparently she appears to be fixing with the right eye, at least in the photograph. Her stereopsis was less. I decided to do 3 muscle surgery, 9 millimeter of lateral rectus resection with medial rectus resection. This is the post-operative result which I got at 1 week post-op. I counseled the patient that she will need second surgery. The moment you get exo after the first surgery, it mostly will develop over time and will need another surgery. So the patient was dissatisfied, and she took her own sweet time. She came back to me after a year after the first surgery. I had option of either going for the medial rectus in the right eye or the lateral rectus, one virgin muscle was remaining. So I went for that resection in that eye, and ultimately I got the correction which was desired by the patient. So there are many factors which actually govern the surgical outcome or alignment outcome after an exotropia surgery. One is you should have a good thorough preoperative workup. This applies for all strabismus entities actually, and give proper chair time to the patient, explain about the post-operative outcome, what to expect out of it. Create your own algorithms depending upon your experience with time. Diligent surgical steps, if I have time I will share that, and also post-operative care. Now coming to preoperative planning, do a good preoperative evaluation including cycloplegic refraction and a detailed sensory and motor evaluation. I mean, if there are certain general ophthalmologists here, use the prisms to measure the squint. Don't use the Hirschberg, at least not when both the eyes patient is able to see properly. Always look for suppression, diplopia and lateral concomitants. Avail non-surgical options, at least in the initial phase when the binocularity is still maintained, the patient is not much bothered by the squint, perhaps less than 50% of the waking hours, then avail the non-surgical options. And surgical options are available, and surgeon should use his own expertise and create his own algorithm actually. So the preoperative tips for exotropia surgery: look for fusional potential, especially in adults. We have seen that if there is poor fusional potential, adult with a bit of exo, they appear cosmetically more acceptable compared to having an ESO. So don't try to overcorrect them. Always determinant for surgical decision making is the constancy or intermittency of the squint and not the angle of the deviation. So if there is one patient with a 25 prism diopter of constant exo, he will need surgery, but somebody who has a 50 prism diopters of an intermittent squint which doesn't present much, then he will, it's okay if you wait for some time. What all are the factors which determine the effect of squint surgery? One is that the smaller eyes, hyperopic eyes, they have more deviation per millimeter compared to larger eyes. children, they give more correction compared to adults. Also, if it's a recent squint compared to a long-standing squint where the tone of the muscles might be disturbed, the surgical outcome might be slightly unpredictable. Also, if the deviation is large, then the chances of per millimeter correction are more compared to a small angle deviation. If there is a lateral incompetence, then we tend to undercorrect the lateral rectus recession. So that is something which you need to measure. Also look for patterns which Dr. A and B pattern, which Dr. Stuti has already been mentioned. That will be covered subsequently, so I'm not covering that part. Then certain algorithms which you can apply. Actually, algorithm you have to create your own, but there are certain general rules which you can apply. Like lateral rectus recession can be done a single muscle if the angle is between 15 to 20 prism diopters, but anything beyond that, a single muscle recession will not help. Either do recess resect or bilateral recession. Now, which is better is a debatable topic. So, I mean, that depends upon the surgeon's experience and the patient's. Some patients may not opt for bilateral surgery. Also, the surgical dose depends upon the angle of deviation, obviously. But anything beyond 45 prism diopters, it's better to go for 3 muscle surgery. Anything beyond 75 prism diopters, 4 muscle surgery has been recommended. Personally, I don't usually do 4 muscle surgery. For large angle deviation, either you do 3 muscle surgery or even you can transplant the muscle. Resect a medial rectus to the lateral rectus on the other side. Coming to, surgical decision making also depends upon the deviation for distance as well as for near. If it's a basic exotropia where the distance for deviation near is the same, you can opt for either recess resect or a bilateral recession. If there is a divergence excess or even a pseudo divergence excess, then prefer a bilateral recession as the surgery of choice. In very few cases of exotropia will have convergence insufficiency and they will need surgery. In those cases, you can directly do a bimedial resection. But remember, for all other cases, you will not have a resection effect unless you do recession. So recession is always the first the surgery of choice, and then only opt for resection. So what should be the, there is a school of thought that you should aim for overcorrection of around 5 prism diopters after exotropia surgery. But there is another school of thought which feel that no, you aim for orthophoria in all the cases. They have found good results even in the long-term alignment. So another few things which you need to counsel the patient beforehand. In spite of having a good correction, the patient might be dissatisfied if you are not explained about something like a pseudo exotropia, like hypertelorism in this case, or if you are doing a unilateral recess resect, explain that the globe will appear retracted and there will be congestion of the eyeball. Very simple things, but we need to explain this to the patient beforehand. Explain the need for surgery and the realistic goals out of the surgery. Never commit yourself 100%. The correction might be 75 or 80% only. And if there are chances of recurrence, especially for sensory exotropia, that also you need to tell the patient beforehand. Another way, if you want to convince the patient for surgery, something, tell him that the angle may not be as large as it is right now. So chances of diplopia, even if you have a prism, prism doesn't reveal any diplopia in the preoperative period, the patient might complain of diplopia in the early post-op, at least first week. So that is something which you need to tell the patient during the chair time, and obviously documenting the notes properly. So suppose a 22-year-old male, who had a large angle deviation. I did a 3 muscle surgery. Many of the times, almost 90 to 99% of the cases, you can get away doing a 3 muscle surgery, even if the angle is really large. That is bilateral recession and a resection of one of the medial recti. Just a couple of cases before I close. 25-year-old male, he had an angle of around 45 prism diopters. I decided to do 2 muscle surgery, a recess resect in one eye, and at the end of it, I couldn't get a proper correction. Actually, he was still residual of around 25 prism diopters. Luckily, I had counseled the patient very well, so he decided to undergo the second surgery immediately. So counseling becomes very important when you are planning for a surgery. Accept suboptimal results. Don't go into denial mode that there is no undercorrection or overcorrection, and revisit all the surgical notes and the videos if there is something which you have missed out. And if there is surgery needed, plan it early so that you can, the patient dissatisfaction will be less. And if you want a second opinion, have a pool of strabismologists in your town to take a second opinion from. So in this case, I went for a recess resect in the other eye in order to get the correction. A similar patient profile. This was one patient who had around 45 prism diopters of exotropia, and a similar age group, but somehow with a single recess resect, I was able to get the eye straight. So sometimes, I mean, a latent nystagmus might be a challenge, especially if it is exotropia. Like in this case, he had an exotropia and very strong face turn in order to avoid the nystagmus. Even when I was trying to correct his face turn, he was, I mean, very reluctant to do that. But his main concern was exotropia. So I decided to do a unilateral recess resect in the left eye, and in addition to correcting the exo, I could get away with a good I mean, correction of the abnormal head posture also. So before I close, I have some 45 seconds. I'll just explain to you how to, this is basic recess resect. Remember that if you are planning to do resection, this is recession of the left lateral rectus. Ensure that all the muscle fibers are involved in the suture, and I normally pass two separate sutures, 60 Vicryl, and I mean, don't miss any fibers, because the result might be slightly unpredictable if you tend to miss out on them. And don't have any loose knot. This applies for the resection also. So I'll just show the video of resection actually. Then when you are disinserting the muscle, do the disinsertion very slowly. I mean, don't engage the sutures when you are disinserting the muscle. And so because if you engage the sutures, then obviously further surgery will be difficult for you. And marking can be done either using a ink, I mean the blue ink, or when you are passing, it should be superficial and it should be longer. So don't go very deep. The edge of the needle should be very much visible throughout, and ensure that the muscle is properly opposed to the sclera. So with this, I would like to conclude by saying that careful preoperative evaluation and surgical planning is very important. A thorough preoperative counseling is equally important. And if there is a pseudoexotropia, you need to explain that beforehand. Create your own algorithm, and accept suboptimal result, and counsel the patient and relatives accordingly, and treat as early as possible. These are the references. Thank you.